My name's Stephen Duckett. I'm Director of the Health Program at the Grattan Institute here in Melbourne, Australia. And I thank you for listening to me today as I talk to you about COVID and the potential COVID responses. Basically, I want to set the scene by talking about what I call the corona cycle. So the coronavirus obviously leads to a public health response. And this is affected by the adequacy of the public health infrastructure. Here in Australia, we've seen differential responses in the different states, as some have had better and some have had worse preparedness because they've had better or worse public health units scattered throughout their state. And it's something that you can see in different countries as well. Depending on how effective your public health response is, you will get infections. And again, the infections are to some extent have certain antecedents. Crowded housing, for example, we had outbreaks in social housing estates here in Victoria. Itinerant workers, both in terms of people who share workplaces and work between different workplaces, can transmit infections from one workplace to another. And also the economic support. So if, for example, we've introduced in Australia pandemic leave, so people can get leave to go and be tested, leave to stay at home, a payment to stay at home if they're infected. And if you don't have those sorts of economic supports, then you're possibly going to increase the number of infections. Obviously, infections will increase healthcare use, hospital use and so on. Particularly in some cases intensive care use. Another impact of the virus is the increase in population anxiety. The population is concerned about contracting the infections, and that will be affected by the adequacy of risk communication, and the level of population anxiety may change over the course of the pandemic. Interestingly, the increased population anxiety will actually reduce healthcare use. People will be scared about going to their GP, their general practitioner, family physician for a condition. There may be a reduction in cancer screening, for example, as we've seen in Australia. And so there'll be a change in the nature of healthcare use. The most obvious is the use of telehealth, which really burgeoned in Australia. Now, the public health response includes lockdowns, and those lockdowns will also change healthcare use. But the lockdowns, the restrictions, will also have a secondary impact on the population, including, for example, increased mental health presentations, conditions, increased drug and alcohol conditions, increased domestic violence. And often those secondary impacts were not in the pandemic plans because lockdown wasn't contemplated. And so they've been badly planned for here in Australia anyway. Of course, the lockdowns also have an economic impact as businesses are closed, and that contributes and exacerbates any secondary impact. The public health response includes a number of things like mobilising the system, testing, and we can learn from the pandemic in terms of how effective we were in community engagement, how effective did the population accept all the restrictions and so on. One of the other important effects of the pandemic is that it has not been evenly distributed across the whole society. That is, there are distributional effects of the pandemic with lower socioeconomic classes having more of an impact, partly because of the industries they're in, partly because of overcrowding in their housing, and so on. Increased healthcare use is impacted by access to testing in the United States. For example, testing wasn't covered by many people's insurance, and so they actually didn't get tested, and so contributed to a bigger spread. And similarly, access to care, as I've already talked about, is really critically important. And finally, the economic impact is also impacted by socioeconomic status and so on. In Australia anyway, the change in healthcare use, the primary care system was an afterthought. That is, most of the initial response was through hospitals, and which I think was a significant weakness. Anyway, the issue of lockdowns is an important one, still a continuing debate here in Victoria, in Australia. The issue is the balance. So yes, we're aware of the secondary impacts, we're aware of the mental health impacts and the drug and alcohol impacts, but the restrictions help to reduce both the current impact of the pandemic and also the likelihood of future pandemics, future waves, third, fourth and fifth wave. In Australia, about 40% of the population has been identified as being at higher risk of infection, including everybody over 70, people with some chronic conditions. And so, you know, this is a serious issue. And of course, because there are so many people who are impacted by the pandemic, it means that the response to the pandemic has to be good, because, you know, if you're going to if 40% of the population are at risk, then you can't just say we're just going to isolate those people at risk, because it is such a large proportion of the population. Our response to the pandemic has been influenced by the science, and the science basically says that there's less transmission outdoors than indoors, low occupancy is safer than higher occupancy, well ventilated better than poorly ventilated, and masks are safer than no masks. And that has shaped the nature of the response. So Australia, in Victoria anyway, we're in stringent lockdown. I'm only allowed to go outside 2 hours a day. There are only 4 reasons why I can go outside. One of them is not going to work. My workplace is not an approved place for me to leave the house. And so there's been reduction in mobility, reduction in economic activity, and as I said, stringency. The average there is the Australian average. It's different in Victoria. So what I want to mostly talk about is, where do we go from here? Let's assume we come out of the pandemic. There has obviously been some learnings, some lessons that have been that we've got from the pandemic. So how will we plan after the pandemic? What will the new normal look like? Well, the first thing is, the new normal won't just happen. That is, if we don't purposely do something, then the system will slip back to the old ways. And I'll give you a couple of examples of that in a minute. The new normal has to be managed. And so if you accept that, then you have to say, who is going to be part of the planning for the new normal? Who will be sitting around the table planning what that new normal look like? Will it just be the insiders, the hospital chief executives? Will it be a more broad-spread issue involving consumers or not? And so this issue of who will be at the table is actually an important one, because you have to plan, you have to think about what your engagement strategy is. And the other issue is, what will be on the table? What will be allowed to be talked about? Because if you decide you're just not going to talk about particular issues, that's a decision, and it's a critical decision about what your agenda is allowed to be. So in our work here at Grattan, and I should have said right at the start, we've done a couple of reports on this, and they're on the Grattan website, grattan.edu.au/health. And we looked at lessons to be learned from the pandemic, and I just want to concentrate on 4 of them. Improved access through telehealth, outreach, new primary care models, improved convenience, and improved efficiency. One of the things that happened here in Australia was we cancelled elective procedures to make room for a possible influx of patients, a significant number of patients infected. As it turned out, we didn't need to, but nevertheless, elective procedures were cancelled for a particular period of time. Hospitals are basically back on track now. But the point is, as hospitals go back on track, need they go back on track? Need they be doing the same things now that they were doing in the past? So we've got to think about, what should we do differently to clear the backlog of the slowdown, and we need to think differently about how we manage elective procedures in the future compared to in the past. And I've got 3 ideas here. So in Australia, every hospital has its own waiting list. They do, and sometimes each hospital has multiple waiting lists. The orthopaedic unit might have 5 separate waiting lists as to 5 separate orthopaedic teams. Obviously, we know that a single queue, a single waiting list for hip replacements across multiple hospitals will mean quicker treatment on average for everybody. If you have multiple queues, the more queues you have, the more sometimes one queue will go fast and one queue will go slow, and as a result, the overall waiting times will be higher and less efficient and less equitable. So we've argued you should centralise the queues, centralise the waiting lists. Secondly, you should review the waiting lists. And by this I mean, for example, we've got unnecessary care, low-value care taking place in Victoria. Knee arthroscopies, for example, for osteoarthritis of the knee is happening frequent enough, and the evidence is it doesn't do any good. So we need to actually make sure we're having clear criteria for what is allowed to restart. Let's use this as an opportunity to say we can actually start to think about, especially if you've got a centralised waiting list, we can think about, are we actually going to introduce the old ways and let all these low-value care take place, or are we going to use this as an opportunity to introduce new ways of doing and get rid of the low-value care? And thirdly, we've got to think about modernising the system. So, you know, the whole approach to treatment should be changing, should be saying, are we using the right length of stay? So, for example, can we really transform the length of stay for orthopaedic surgery so we have a much higher proportion of same-day procedures? So, as I said here, getting rid of low-value care, also looking at non-surgical pathways, thinking about, you know, does everybody with a back pain have to go and see a surgeon, or could they see a physical therapist instead? So thinking about what the pathways into care looks like, and revolutionise average length of stay, and also look at whether everybody is fit for surgery, such as, you know, what are we doing about smoking and so on. So really use this as an opportunity to modernise the system. Then we need to think about modernising the workplace. And so over the last few decades, there's been a revolution in the way we train physical therapists, the way we train nurses, and nurses and allied health personnel can do way more than they used to do. And are we letting nurses and allied health personnel do as much as they can? In Australia, we have podiatric surgeons who are podiatrists trained as surgeons. We have sedation nurses who are able to sedate patients undergoing endoscopies. So, you know, we can have nursing endoscopists doing endoscopies themselves. So, you know, to what extent are we implementing full scope of practice to actually get rid of, improve efficiency, and also sometimes the waiting lists are associated with limited number of surgeons, for example. Similarly, are we using midwives adequately? Are we, rather than obstetricians? And if a nurse has got a credential to be an endoscopist at one hospital, is that recognised at another hospital? So what are our processes to mean to allow workforce flexibility and workforce innovation? One of the dramatic changes in Australia was the use of telehealth or virtual healthcare. And there are a number of ways we can look at this. So there was, in terms of ambulatory services, hospital outpatient services, massive shift into outpatient, to telehealth, to virtual care. And the question is, now the pandemic is coming over, what are we going to go back to? Are we going to go back to the old ways where practically all of the ambulatory services were face-to-face? Or are we going to say, no, we're not going back to the old ways. We're going to have a target. So 50% of our non-admitted patients will be by virtual care. And I might just slip there to the third point I've made there. Should we offer every patient virtual care as a choice? That is, we can say to the patients, you don't have to line up, you don't have to come here. We are prepared to do this in your own home, either by telephone or by video or by some other virtual healthcare strategy such as telemonitoring. We want to reduce the number of people who are fronting up to hospitals. So what do we do to support family physicians who need a second opinion? And so rather than sending the patient for the second opinion, they might be able to ring up the patient, the specialist, and say, this is the patient in front of me, this is the conditions they've got, these are the tests I've done, what should I do next? If I sent this person to your clinic, what would you do? And can I do that? So change the dynamics, the flow of patients. And I've also got their home monitoring. The telemonitoring has dramatically improved in Australia. We're not particularly good at paying for it, so it's not as productive as it could be. Finally, looking at integrated care. As I said right at the start, we didn't use family physicians very well, so we need to think about general practice and family physicians and how the hospital system engages. In Australia, in Victoria, we are developing statewide care paths. That is, we're developed a computer system which has embedded in it care paths, and these are on the desktop of every family practice, family physician. And if you want to refer a patient to the hospital, they will say these are the criteria we need for referrals and so on. So we're trying to increase the evidence base for practice. I've got an abbreviation there you won't recognise, but HITH stands for hospital in the home. So GP, how are we involving family physicians in hospital in the home, in intensive hospital care delivered in the home as part of these virtual care arrangements? And finally, looking at the question of bundled payments, looking at how we change the payment system to encourage care out of hospital in low intensity settings at a much cheaper rate and much more efficiently. And this is a systematic review which has been done, which looks at the impact of bundle payments in the United States. But what it shows here, and the most important thing about this particular slide, is that the bigger the bundle, especially if it's hospital plus physician plus post-acute care, the more likely there is to be an impact on spending. So there's lots of studies here, not all of them showing good results, but what it's trying to show, what I want you to see from this is that when you're thinking about bundled care, bundled payments actually do reduce spending, but you've got to think about what the bundle is. So that's my talk here, that basically when we're coming back from COVID, we really need to think about what are we going to do differently, how are we going to do it, and how are we going to plan to do things differently. And I think there are a number of areas where we can plan to do things differently, and that's what I've talked about today. So thank you very much.